day, everyone. We're going to start this lecture with Chapter 1, The Business of Medicine, and we're going to begin with just discussing the objectives that will be discussed during this presentation. Initially, I do want to share that healthcare is a multifaceted industry which employs all types of professions and is bound for a multitude or by a multitude of statutes and regulations. So to help you further understand that, we're going to walk through this presentation together, talk about some of the coding and billing aspects, because coding and billing are different steps in the revenue cycle process. And we'll also talk about payers, documentation in the medical record, medical necessity, ABNs as it pertains to Medicare patients. And then we'll also discuss coding as a profession, how coders fit in, working in a hospital versus a physician's office, and then the hierarchy of medical providers. So it's also going to be important to discuss the varying regulations that affect us as a coder. And some of those regulations are, or most of those regulations are, federal guidelines that we do have to adhere to. And they kind of coach us and guide us in how things should be specifically coded or even documented on the physician side. You know, there's regulations that tell them how things should be documented as well. It's important to understand HIPAA, the Privacy and Security Act, compliance rules. We're going to wrap up the end of this presentation talking about specifically the American Academy of Professional Coders. So let's start with coding as a profession. And the coding profession has evolved significantly over the past several decades into a career path with unlimited possibilities. Many professionals who have learned coding have also gone to roles as consultants, falling under specialty coding, as educators, which is what I'm currently doing, or medical auditors. And there are endless possibilities. There's also practice management is another area of specialty that you can get credentials and certified in. So what is coding? Every time a patient receives treatment or care, a medical record is going to have documentation about what that treatment entailed, whether it was an office visit, an injection, a surgery, a vaccination. There's always going to be documentation as in regards to what service was provided to that patient. Coding is the process of translating that written documentation or that dictated medical record into a series of numeric or alphanumeric codes so that they can be billed to the insurance carrier. So coding, or the codes themselves, is the way that physicians' offices and hospitals communicate with the insurance companies. Coders often use computer programs to tabulate and analyze data to improve patient care, better control costs, provide documentation for use in legal actions or use in research studies, which the Medical University of South Carolina, is a place that's really big on research study. Even still, if it's not being billed to the insurance, there still has to be codes applied to these, to every service that's provided to a patient. Technicians who specialize in coding are called medical coders or coding specialists, but the credential or certification that you may hold could be the CPC, which is Certified Professional Coder. It could be a CCA, which is a Certified Coding Associate. It could be a COC, which is a Coding Officer of Compliance or Certified Officer of Compliance. Or it could be a CCS. These are just to name a few. CCS is Certified Coding Specialist. All of them carry the same weight as far as what employers are looking for when they seek to hire people. So medical coders, as in your role, coders assign a code to each diagnosis and procedure by using a classification system. So you have the 3 different books that you can utilize to assign codes from. Those are the classification systems they're referencing, whether it's CPT, ICD-10-CM for your diagnosis, or HCPCS Level 2 for any drugs, equipment, or supplies. Coders may also use several reimbursement systems, such as those required for ambulatory settings, physicians' offices, or long-term care, basically meaning that anywhere that you work, they could have a different type of electronic medical record. They could be using Epic, Cerner, Meditech, ECW. There's so many different type of electronic healthcare records, or EMRs, electronic medical records, that are government approved, and all work very similarly, but to help protect the information of the patient and house the information of the patient in one central location. Physician-based coders review charts, assign CPT, HCPCS, and ICD-10-CM codes for insurance billing, and this is tied directly into physician reimbursements, and careful thought to assigning the correct code is essential for the doctor's livelihood. So this is how they get paid, how the hospital gets paid, essentially how we get paid, is through our coding and the accuracy of our coding. Coding technicians who specialize in coding for hospitals are called health information coders, medical record coders, coders or abstractors, or coding specialists. These technicians assign a code to each diagnosis and procedure, relying on their knowledge of disease processes, and coders then use the classifications mentioned, diagnosis, CPT, or HCPCS Level 2, to appropriately assign the code. Further in this slide, you can just see, as I was talking about, other types of names that coders can be labeled as, HIM, or health information coders, medical record coders. So as you're looking for, your job search, I recommend that all of you go to Indeed.com, and that you just do some job searches on available coding vacancies, and utilize these different titles that they give. They all mean the same thing. They're just titled differently based on the type of organization: hospital, doctor's office, labs. I don't really think there's a rhyme or reason. They just pick how they want to title their coders. Inpatient coding, patients that are admitted to the hospital, they use a different coding system, and that is the MSDRG system, which we will not be teaching in this class because it is not a part of the curriculum for AAPC. And this class is geared towards outpatient coding. Coding is a rapidly changing profession. It's very unique. Once you master the concepts of coding, you will be required to participate in continuing education and ongoing education annually in order to maintain your certification. And that's because, as we talked about in class, medical advancements pose a need for new codes, for codes to be updated. Sometimes they'll have the code may need more detail in it. It may need to be more specific. So they'll add a character to the code, or they may change the description of the code. Or like we have seen with COVID, where they just have to add new codes because there is no, or was no, diagnosis code to identify when a patient was diagnosed with COVID. Or, thinking long term, if the patient had COVID, recovered from COVID, but still had to maintain or still be on oxygen once they get home, then now they have a condition of respiratory impairment due to COVID. So they also had to create new diagnosis codes in relation to after effects of COVID, in addition to COVID. So as they're still learning what these after effects are, they're going to continue to create new codes to identify those conditions. In addition to mastering anatomy and medical terminology, coders must be very detailed. So anatomy and terminology is going to play a huge role in your understanding of the codes and the things that you're coding and reading, which is why for every chapter, you'll see as you're reading in your textbook, there's going to be medical terminology specific to that chapter. There's going to be anatomy specific to that chapter. So as we go forward, I would really like for everyone to kind of think about your method of learning. I highly, highly recommend making index cards of the medical terms that you see or the vocabulary terms you see at the end of the chapter that you've read. And I think that would be extremely helpful to your success in helping to retain some of that information. Hospital coding versus physician services. The biggest difference is the location in which the service was provided to the patient. That's, the main thing. But also, when you visit a physician in the office, you typically get one bill for the doctor. But when you see a doctor in a hospital, you may get a bill from, like, the emergency room, for example. You typically get a hospital bill that's for use of the facility and the equipment within the facility. And then you get a bill for the ER doctor. If they did any x-rays, you get a bill for the radiologist. If they did any labs, you get a bill for the pathologist or for the lab. So every service that's provided in different specialties can be unique and can require additional billing. But we'll get much more into that as we get further into the course and we get to those specialty areas of radiology, pathology, anesthesia, and etc. So codes for the physician services report the work and overhead of the doctor regardless of where the work is performed. A physician can provide inpatient or outpatient services and can provide those services in a clinic, an ambulatory surgery center, a hospital, or other location. The physician services are reported using CPT, HCPCS, and ICD-10-CM codes, and those services are typically billed on this form, which is called a HIPAA. This is a form that was created by CMS, which is the Center for Medicare and Medicaid Services, which you'll learn is one of the largest government entities that that oversee coding processes, coding education. Medicare is just not an insurance company. It is much, much more. It is actually a division of the OIG, which is the Office of Inspector General. And also under the OIG falls all of our DHECs, our local health departments. They all kind of report to that hierarchy of the OIG CMS. Further in with hospital versus physician services, hospital-based medical coding. Remember I talked about how you would get a separate bill for the hospital? Well, they call that the technical component because it is the technicality that states, you were seen by a doctor in the hospital. The doctor's going to bill you. So now the hospital is also going to bill you because you utilize their space to get treatment. Hierarchy of providers. So you hear about physicians, PAs, NPs. So it's important to understand where those fall. Physician services are provided by a variety of medical providers. So physicians doctors undergo 4 years of college and 4 years of medical school. So that is an 8-year commitment of college. They also are required to either train in a residency, either 3 to 5 years. So misconception, when we go to the doctor, maybe a teaching hospital, and they say, I have a medical student here, and we're thinking, oh no, I don't want some new doctor working on, or some student working on me. But this student has already attended 8 or more years of college, and now they're in their residency. So they're qualified enough to treat us, and they're supervised by the attending physician. They're always supervised. No resident can see and treat a patient without the supervision of a doctor. So Anytime a resident may see you, a doctor always has to approve of whatever their treatment plan is going to be for you. So underneath the physician, you have your PAs and NPs. The reason you see them on level ground on this graph is because they really are um, in lines of billing in the hierarchy. So physicians often have what they call mid-level providers, and that's these NPs and PAs. Mid-level providers are known also as physician extenders because they extend the work of a physician. Physician assistants are licensed to practice medicine with physician supervision. A PA program takes approximately 26 and a half months to complete, and nurse practitioners have a master's degree in nursing. So they too are very highly qualified in order to treat you. I see a nurse practitioner for my healthcare, my primary care doctor. The only thing that they cannot do is they can't see you as a new patient. So, and if they do, they are still supervised by the physician. Anything that they recommend for your treatment, they are still supervised by the physician, and he has to sign off on their records. Mid-level providers are often reimbursed at a lower rate, so they can bill the patient's insurance or the patient for their services because they're considered mid-level or physician extenders. But they don't get paid as much as a doctor would. That's the difference. Each state has special regulations on the scope of practice that these mid-level providers can handle and accommodate as extenders of the doctor or the physician. But these hierarchy of providers, so this last row, these individuals cannot bill for, well, physical therapists can, but a radiology tech, a lab tech, and the nurses cannot bill for their own services. Physical therapy is a specialty service that allows the therapist to bill you separately. So let's talk about payers, and all of those things I just said are payer specific, they're payer based. So a patient can be a self-pay, meaning they have no insurance, or they can be insured. You can have private insurance, which would be like your Blue Cross Blue Shields, your Aetna. But insurance carriers are broken down into two groups mainly, private and governmental. So these are your privates, examples. And then your governmental would be like your Medicare, Medicaid, TRICARE. Medicare is for persons age 65 or older, or those with um, conditions that are considered a disability. Medicaid is for low-income families sponsored by the state and federal. And then TRICARE is for active duty military members, military service members. Commercial carriers can offer both group and individual plans. So that's your commercial and private is the same thing. So this is why a lot of your jobs or your employers have, Blue Cross Blue Shield. They could be, if you're a state employee, it'll be Blue Cross Blue Shield state. If you're federal, it could be Blue Cross Blue Shield federal. Next slide. Medicare has 4 parts. So this is going to be one of the questions that I know for certain is on your practical application. So you'll have to be able to identify the 4. If you look at this definition, Part A, Medicare is for insurance hospital care. I'm sorry, inpatient hospital care only. The Part B is for physician services for your outpatient care. Part C is managed care by private insurers and may include a combination of Part A and B. Sometimes Part D, and then Part D is your prescription drug plan. So there are newer types of Medicare Part Cs that include all of those, but for the most part, A is for inpatient hospital care only. So it could be hospice, home health care, being actually in the hospital. B is for your doctor's office, outpatient things. And D is for prescription drugs. And C is private insurers like your Aetna or Humana. Humana is a good example. The medical record is a record of pertinent facts and observations about an individual's healthcare. It is very private. The medical record chronologically documents patient care to assist in continuity of care between providers, facilitates claims, review and payment, and can serve as legal documents in court. So it's very important for doctors to ensure that they're consistently documenting a patient's record. A coder is required to read and understand the documentation in a medical record in order to accurately code the services rendered, and different types of services are documented in a medical record. So it's going to be everything that the doctor deemed as necessary, medically necessary to care for that patient. Um, to give an example of what a medical record may look like, or a clinic note, let's say you go to your doctor's office, right? Regular office visit, you had a headache for a week, so you decided to go to your doctor. That note is going to be broken up into 4 parts in perspective for the doctor's documentation. The subjective would be patient presents with headache times 7 days. Patient has tried Tylenol. That did not work. Patient also complains of blurred vision and nausea. That's the subject. Why is the patient here? The objective is the provider's assesses and documents the patient illness using observation, palpation, auscultation, and percussion. So this is where they're examining you. They're checking your vital signs and your blood pressures. They are looking into your eyes and seeing how your pupils react to light. They're touching you and seeing how, checking your oxygen. They're doing all of these things, so that's objective. They're actually examining the object, which is the patient. The assessment is the evaluation and conclusion made by the provider. So this is where they have come to a diagnosis. Diagnosis may be hypertension. If they did all of the examination, they checked your blood pressure was high. They maybe ordered some labs to get a further, idea of how your body is reacting. They looked at your ankles and your legs and saw that they were swollen. So in the end, they come to a conclusion that this patient has hypertension. And then the plan is going to be the course of action. How am I going to treat the hypertension of this patient now that I've come to a conclusion in the assessment that that's what they have? And it could just be prescribed medication called into pharmacy. That's the course of action. Patient will return in 3 months for follow-up. The operative report documentation. So if you have a surgery, this is what, and you're a surgery coder, this is going to be the exact type of documentation that you'll see in a surgery note. So you'll have a date and time of the procedure. That's typically going to be at the bottom or maybe somewhere at the top of the note. The name of the surgeon, co-surgeon, and assistant surgeon, and you can see the surgeon name here. Assistant here. Type of anesthesia is general, that's here. Estimated blood loss, that's required documentation by federal law. You'll always see that. Complications also required by the law. Total tourniquet time, indications, which would be what brought us to the point of surgery. In this case, the patient had right knee painful popping. Description of the procedure would be everything from the time that they started, they put the patient on the operating table until the time that they finish with that patient. So this is a typical surgery note. And at any point, if you feel like the presentation is going super fast, you can pause or always go back. And that's one of the beautiful things about utilizing YouTube. Operative report documentation, the body might include, as we saw in the previous slide, the indication, details of the surgery, as well as findings. Coding tips for operative surgery coding. And I kind of want to skip this just because we're not going to get to this until chapter 6, but I do want you to see the slide. So you always want to identify words that you're not familiar with, like medical terms, anatomic landmarks, medical procedures. And then there's an op note on the next slide. So here it's pointing out some anatomical things here, anatomy. So intra-articular, which means inside the arteries, space. ACL is the space inside of the knee. We saucerized. If they had to saucerize it, that means they used, some type of heat mechanism. The anterior horn is a directional point to tell you if it was on the front of the knee or the back of the knee. This is getting down to a suture and how they tied the suture. So literally every ounce of detail pertaining to that surgery is going to be listed in the description of the procedure, and that's what you'll be coding from. So you want to use the postoperative diagnosis for coding unless there are further defined diagnoses or additional diagnoses found in the body of the operative report. If a pathology report is available, use the findings from the pathology report for the diagnosis. Taking a look here, you have a postoperative diagnosis. So the reason that we use the postoperative diagnosis is because the pre-op is the reason that they went into surgery. The post-op can be different. They could have gone, opened up the knee, went inside of the knee, and found that the reason they went in there was different than what they actually found when they opened the patient up, right? So that's why we always code the post, the after, not the pre or the beginning, but we call the post-operative diagnosis. You want to start with the procedures listed. So just, I want to go back to the previous slide. Well, actually, no, I don't. I want to go to the next slide. Starting with the procedures listed. So it told us on the operative report that the procedures performed were the right knee arthroscopy, lateral meniscus saucerization, lateral meniscal pair. So here's giving you at least a preliminary idea of what surgeries were performed. You still want to read the description of the procedure to make sure that it lines up with this, but you can utilize this as your starting point, the procedure performed. So that's a good tip for when you do start coding surgeries. You also want to look for keywords. And looking for keywords, it could be locations, as mentioned earlier, surgical approach, procedures, method, like was if the patient had a boil, maybe they needed to do an incision and drainage. Maybe they just needed to drain it with no incision. You know, it's going to be those types of keywords that you see. Procedure type, or if they had to make an incision, how they closed the incision. Size and number. Anytime you have sizes or a number, that's going to be important. And then surgical instruments used during the procedure. So this gives us all a little bit of all of those things. And this is the same note that we looked at before. So if we just take a deeper dive, again, we see that the patient was placed on the operating table, administered preoperative antibiotics. Eventually they came in, okay. The standard 3-portal knee scope was performed. On evaluation of the intra-articular space, cartilage throughout the knee looked in great condition. The medial meniscus looked in good condition, and the ACL was intact. So they turned their attention to the lateral meniscus, which was one of the key areas that needed attention, which was the reason that brought the patient to surgery. All procedures reported should be documented within the body of the operative report. That's why you also want to make sure you're reading that. The body may indicate if the procedure was complicated, extensive, if it was abandoned, or if there were extra time. And if there was extra time, then there's certain things that we have to do. If in any of these instances, there's certain things that we need to add to the code to identify those things. Medically necessary or medical necessity. So with medical necessity, this means that we want to only code services or supplies that are, well, let me say it like this. According to CMS, the definition of medical necessity is services or supplies that are proper and needed for the diagnosis or treatment of your medical condition. So if you went in and you had chest pain, they don't need to do a foot x-ray. It makes no sense. Has nothing to do with your chief complaint. You came in for chest pain. They should focus on your chest area. Medical necessity is also treatment of or supplies that are provided for the diagnosis, direct care, and treatment of your medical condition, that they meet the standards of good medical practice, and that they aren't mainly for the convenience of you or the doctor. Convenience of the doctor would be just for additional payment. Convenience for you would be, let me just do the foot x-ray just because I want you to. No, they don't do that. If they say you coming in for chest pain, they focus on your cardiac system first, and then they go into other areas. NCDs and LCDs, so CMS, these are regulations that govern medical necessity found in the Social Security Act. So another federal guideline that has a connection to medical coding. CMS develops policies based on items or services that are covered by the Act, and CMS is not allowed to cover any items or service unless it has been put through the legal requirements. So the statutory and policy framework within which the NCDs, the National Coverage Determinations, are made by may be found in the 28 of the Social Security Act, Title 28 of the Social Security Act, and in Medicare's regulations and rulings. So this is a part of Title 28. NCDs describe whether specific medical items, services, treatment procedures, or technologies can be paid for under Medicare. MAC, which is Medicare Administrative Contractors, are responsible for interpreting these national policies into regional policies, and they are called local coverage determinations. So every state or in region has a MAC, or Medicare Administrative Carrier, that will interpret those policies. And then we have those regions that are broken up into jurisdictions. So like in South Carolina, we are, I would try to remember this. Our MAC is the Palmetto GPA, and I believe that we're jurisdiction 11, but that's not necessary for you to know. I just know just because of the, having a look at it. So what an LCD policy will look like is very similar to this, and it will literally tell you if the patient is coming in for routine foot care, right? And if there's a specific code that they will only pay for the foot care if these diagnosis codes are used, or if this procedure code is used. And that's the type of thing that we see in this LCD, is we see specific codes. Like in this example, if the patient has ALS, if they have chronic indurated cellulitis, chronic venous insufficiency, Raynaud's disease, peripheral vascular disease, then they'll pay for the claim and it'll get paid for. Let's move on. So this is an example of what those diagnoses, plural, or diagnosis codes would be that also would be covered under that policy. So in a real life coding world, there are systems in place that tell us, built into the system, when we're coding something, that'll alert you and say, hey, you need to look at the LCD for this to make sure your diagnosis is correct. So it's not something that in a real world of coding that you would have to, again, memorize, nor is it something that you would have to memorize necessarily for the class. Just be familiar with what medical necessity is, or medically necessary services. ABN, so those of you that may be of the Medicare age, or have family members of the Medicare age may be familiar with an ABN. It is an advanced beneficiary notice or notice of non-coverage. Basically, if you go to the doctor and the doctor suspects that a service that they will provide to you on that day is not going to be covered by Medicare, they have to educate you on that and say, hey, patient, we're planning on ordering these labs today, but Medicare does not cover the labs and the charge for those labs is $45. Do you agree? Do you want the doctor to still order those labs for your treatment? Do you not want the doctor to order labs, or and are you okay with making a payment? And the patient will either check the appropriate box that applies, and then they'll sign it. And this stays on file in the patient record. For us in coding, this tells us how we need to code the account. And this is only for Medicare patients. So it's a requirement that they notify a Medicare patient, they as in the doctor's office, whoever's registering the patient, it's required that they notify the patient of any service that Medicare may not cover that they are going to provide. HIPAA, the Health Insurance Portability and Accountability Act, is a law that was established in 1996, and it is a 5-part act, but the part most concerning to the position of the medical coder is Title II, also known as Administration Simplification, which addresses national standards for electronic transactions and code sets, establish unique identifiers for the provider, health plans and employers to be used nationally, and it provides federal protection for the privacy of personal health information. And we all, when we go to the doctor every year, at least once a year, they do give you that notice of patient privacy pamphlet. It's required. Other things within HIPAA. So we talked about the different code sets as far as what you're going to get in the class, HCPCS, TPT, and ICD-10-CM. But there's also a whole completely different set of dental codes. We don't cover that. There's a whole completely different set of national drug codes. We do talk about that, but we don't code the NDCs. We just code the administration of the drug or the actual code for the drug, and that'll be chapter 6. The Health Information Technology for Economic and Clinical Health Act, HITECH. The HITECH law was established in 2009, signed into law on February the 17th of 2009 to promote the adoption and meaningful use of health information technology. It addresses the privacy and security concerns associated with electronic transmissions of health information, due in part through several provisions that strengthen the civil and criminal enforcement of the HIPAA rules. HITECH strengthened HIPAA rules and established more responsibility for business associates applying or complying with HIPAA. So with the HITECH law, one of the things that just kind of stands out, for me in my role is that if I access a record, patient audit trail, perfect. So you as the patient have the right to request an audit trail of your electronic medical record so that you can see who has been in your record, who's accessed your record. Because the only reason someone should be going into your record is to perform their job duties. Like if my next door neighbor or my best friend is in the hospital, that does not give me the right to go into their record to see why they're in the hospital or what's going on with them. If I do, that's in violation. The only reason I should be in there is if it pops up on my screen for me to code it. Then I'm fine. But if I just manually say, I'm going to look in their record and I just poke around, that is not fine. And I could lose my job for that. So this protects the patient. So yes, you can go to your doctor and request an audit trail of your record to see who has accessed it. The violation of the Privacy Act, HIPAA, which is enforced by HITECH. This slide just kind of gives you an example, of a nurse practitioner going into a record. There's tons of more examples available if you want to click on This hyperlink, actually, you can either click on or you could copy the link as you're in the presentation and paste it into another window, and it'll give you some really great examples, but it's just an absolute no-no to look through a patient's record unless I have meaningful use, meaning that it was necessary in order for me to do my job to go into that record. Benefits of a compliance plan. So that's also why every doctor's office and hospital is required to have a compliance plan. Compliance is the law. We want to make sure that everyone is complying with the federal guidelines. So the benefit of a compliance plan is to ensure that we are coding things accurately and we have more accurate payment on our claims and not denials because something was coded wrong or documented wrong. We make fewer billing mistakes. It's diminished chances of a payer audit. Last chance of running afoul or fraud, basically running a foul. Um, increased accuracy of physician documentation. So all of these, and I don't have to read them all in detail, but these are the benefits of a compliance plan. Compliance plans are enforced or required for all by the Office of Inspector General. So we are always audited. We're being audited by Medicare. We're being audited by the OIG. We're being audited by the Department of Health and Human Services. So patients are always protected. MIPS. MIPS is a merit-based incentive payment system. It's a combination of three former incentive programs that were in place by Medicare or federal entities. And what it does is it gives doctors or clinicians bonuses for certain types of care. So you may have, during the COVID, some of these things kind of came up in news and in conversation that these hospitals and doctors are getting money, for saying that they've had more COVID patients. And I mean, it was true. And it was because of incentive programs like this. So just know what it is. The only thing that you'll be tested on is knowing that MIPS is a quality payment program for eligible clinicians, that it does have some exclusions, and there's some eligibility requirements. Is based on 4 different categories: quality, promoting interoperability, improvement activities, and cost. So these are the 4 things. For quality, it must submit at least 6 quality measures during the 12-month period. And honestly, you're not going to be tested on that in the exam. It's just be familiar with it. Same thing with the APM or the Advanced Alternative Payment Models. It is a group of clinicians who have voluntarily come together in an organized way to deliver coordinated high-quality care to Medicare patients. So this is specific to Medicare. And the information on the slide is really all you kind of need to know about it. Again, not something that would be on the exam because the exam is going to be predominantly on coding, but you just need to be familiar with a lot of the business side of healthcare. The last is the OIG Compliance Plan. This is a plan that is put in place annually by the Office of Inspector General for all healthcare entities, hospitals, doctors' offices, to know what the OIG is focusing on as their area of focus every year. It outlines priorities for the Center for Medicare and Medicaid Services, public health agencies. It targets areas for improvement. So one year they may look at fraud. Another year they may look at patient abuse. Another year they may look at, how if patients are getting sick with new conditions while they're in the hospital. So like, patient can have a surgery. After surgery, they develop pneumonia. They evaluate all sorts of things. But they create this plan so that we know what their focus is each year, and that we know that there's areas that we may need to improve on, and if we're audited, that there's going to be corrective action involved with that, which would be in the form of fines. The OIG's work plan is updated monthly on their website, and our compliance managers and auditors are constantly reviewing this to ensure that all of our doctors in our facilities and hospitals are staying in line with the compliance of the federal guidelines that are in place. So that's very, very important. Especially, telehealth was one of their areas of focus due to COVID, virtual visits. It became a thing overnight. So they have implemented that this is one of their areas of focus. They've notified us that they will be doing concurrent reviews and audits on certain Medicare carriers to make sure that they're examining that the use of the telehealth services are effective for the patients, that the patients are still getting the care that they need, and that there's a documentation of the visit of that patient. Same, they're doing that for the hospital services as well as the physician services. Lastly, the AAPC website. So I briefly went through this with y'all on our first night of class. And we saw that, of course, the standard credential or certification with AAPC, the initial or entry level one is the CPC, Certified Professional Coder. But as I mentioned, they have specialty credentials. So all of these, 1, 2, 3, 4, 5, these top 5 are their main core certifications. These next 5 are the ones that are not direct coding, but CPB is Certified Professional Biller, CPMA is Certified Professional Medical Auditor, CDEO is Certified Documentation, I can't remember exactly. CPCO is the Compliance Officer, and then CPPM is the Certified Professional Practice Manager. And then all of these are specialties based on emergency medicine, interventional radiology, cardiac, or that's our cardiac, oh, right here, that's cardiac services. So it breaks down, if you wanted to get a specialty in a particular area, pediatrics. So explore the AAPC website. AAPC was established in 1988 to provide education and professional certification to physician-based medical coders and to elevate the standards of medical coding by providing student training, certification, and ongoing education. And then I mentioned the local chapters where members can continue to obtain education, gain leadership skills, and network. So networking is very, very important. And I want to make sure that you are connected to your local chapter. And again, I can help you with that. But this is the intro to the course, the intro to the business of medicine. So from here, we are going to dive into medical terminology and anatomy after chapter 1. And then we're going to continue on and starting with diagnosis coding. So it's going to be a great ride. If you have any questions, please reach out to me. I'm always available. And I look forward to our next night of class. Thank you.